Today we're going to talk about the echocardiographic assessment of cardiac masses and cardiac source of embolus. So echo, compared to the other imaging modalities, does have advantages. Everybody always assumes it has nothing but disadvantages because it's an old technology. But it has significant advantages, and they include dynamic, real-time evaluation. So you can see what the mass is doing in real time. The extent of the mass within the heart can be determined. The hemodynamic consequences, how it's affecting the valves and the pressures in the heart, all can be determined on echo. And predisposing conditions can be identified, such as an apical aneurysm for that patient with an apical mural thrombus, or rheumatic valvular disease for those patients who have left atrial enlargement, AFib, and left atrial appendage thrombi, and endocarditis. Of course, there are disadvantages of echocardiography compared to CT and MRI, and these disadvantages include suboptimal image quality in about 10 to 15% of patients, resulting in more invasive measures such as TEE, or you just miss the mass altogether. A narrow field of view, so you only see the heart, so you cannot see the extracardiac manifestations of the mass. So if the mass is coming from the lungs or the breast, you can't see any of that. All you can see is the mass that's within the heart itself. There's a possibility of mistaking ultrasound artifacts for a mass, so you really need to know what those artifacts look like and where they occur within the heart so that it doesn't happen to you. And of course, echo cannot provide data on the tissue characteristics of the mass. It can't tell you definitively if it's fat, if it's calcified, if it's fibrous or a thrombus. There are no special protocols to do that like CT or MRI. So we can only infer, we can't say with 100% certainty. So in order to identify an abnormal cardiac mass, you need to know what the normal variants are and where the artifacts occur. And usually we'll separate this into the 4 chambers. In the left atrium, the raphe between the left upper pulmonary vein and the left atrial appendage, which is sometimes called the Q-tip or the Coumadin ridge, can be unusually enlarged in a patient and may look like a mass. The atrial suture line after cardiac transplant in the left atrium also can be very prominent and mistaken for a mass. Artifacts secondary to a calcified or prosthetic aortic valve or a mitral prosthesis or severe MAC also sometimes can be mistaken for a left atrial mass. In the right atrium, the crista terminalis, which is that tissue right before the superior vena cava, can be especially prominent in some patients and can frequently be mistaken for a mass in those patients. A Chiari network or a eustachian valve can also be very prominent in some patients and mistaken for a mass. Lipomatous hypertrophy, especially if it involves the right atrial free wall and not just the interventricular septum, is frequently mistaken for a mass. Of course, pacemaker wires and catheters live in the right atrium, as well as the atrial suture line after a cardiac transplant if it is not a bicaval anastomosis. In the left ventricle, you have papillary muscles, and these papillary muscles can be unusually enlarged. There can be accessory papillary muscles. They can be displaced, so they may not occur in the usual location and may be mistaken for masses, as well as LV tendons and aberrant chordae. In the RV, especially if the patient has pulmonary hypertension, the moderator band and the papillary muscles can be very enlarged and mistaken for masses. And of course, pacemakers and catheters also live there and can be mistaken as abnormal cardiac masses. So what are the 4 different things that you should consider when trying to determine whether or not it's a normal variant, an artifact, or an abnormal cardiac mass? It all starts with, is the mass in the same location on multiple different views? If it is, it's going to be either a normal variant or an abnormal cardiac mass. If it isn't, it's most likely an artifact. For posterior structures, TEE is your friend because the esophagus sits right next to those posterior structures. So if it's a posterior mass, consider a TEE. If it's an anterior mass, probably not going to get much better visualization with the TEE because the transthoracic probe sits right next to those anterior masses. If the image is suboptimal, use echo contrast in those 10 to 15% of patients to bring out those masses. And also you need to integrate the echo and the clinical data to help you determine if it is a mass, whether or not it's an abnormal cardiac mass or a normal variant. So this is an example of a patient. I think we can all see where the mass is. It's in the posterior lateral mitral annulus. It's very echogenic. It is very round and tuberous. And you can see it on all of these views. On the very one on the very right-hand panel, you can see it's not really bothering the mitral valve at all. There's no significant, there's just a trace mitral regurgitation. There's no significant obstruction. So this is a classic example of caseous calcification. Sometimes people call it tuberous calcification or liquefaction necrosis. I've seen all of it. All of this it's a form of MAC, but the inside is very liquidy, so it's very difficult for the surgeon to remove this, and honestly, there really is no reason to remove it, just to recognize what it is. So this is an example of another patient, and you can see in the upper left-hand panel, there is a very mobile structure in the left ventricle. You can also see that in the upper right-hand panel, and you can see that this mobile structure seems to be attached to a mass in the basal inferior wall. When you look on the TE images, you can see that mass is kind of in the basal inferior posterior wall, and that mobile inner structure is attached to the mass, and it goes all the way up to the apex. This is very classic for somebody with an accessory papillary muscle and accessory chordae. It's not doing anything, it's not helping the mitral valve, but it's not causing any harm either. It's just a normal variant. So this is a 55-year-old woman who came with atypical chest pain. You can see her mass. It's very mobile. It's in the right atrium. You can also see that that interatrial septum looks like a jump rope. So that is a classic interatrial septal aneurysm. And when you zoom up, it's in the classic location for a Chiari network. So this would be somebody who has normal variants, and the only concern here is there's a slightly increased incidence for patent foraminal in patients who have interatrial septal aneurysms. So this is a 62-year-old man who came with sepsis. Again, you can see the mass here. It's on the interatrial septum, very echogenic. It's sparing the fossa ovalis. On the right-hand panel, you can see it extends all the way around the right atrium. This is a classic example of somebody with lipomatous hypertrophy of the interatrial septum and the RA free wall. And of course, that mobile tiny mass in there is his catheter, another normal variant. So once you've decided that this is not a normal variant or an artifact and it is a true mass, then the next question on echo is always to determine what type of mass it is. Is it a thrombus? Is it a tumor? Or is it a vegetation? There are 4 different things that can help you when you're interpreting these masses to try and determine that. One is the location. Thrombi occur in the left atrial appendage, in the LV apex if there's an apical aneurysm, or any other part of the LV if there is aneurysm. And they'll also occur in the IVC, the RA, or the RV if the thrombus is in transit. The tumor can occur on all cardiac structures, the pericardium, the myocardium, the left atrium, the right atrium, the valves, a vegetation predominantly on valves. The appearance will help you. The thrombus is always pedunculated or spherical if it's in transit. If it is, it's layered if it's a mural thrombus and attached to an aneurysm. And the tumor, the appearance is going to vary, and the vegetation is going to be very irregular, highly mobile on the low flow side of valves. Associated findings are also very helpful. Thrombus, we talked about the regional wall motion abnormalities. You need that because you need the low flow state in order for the thrombus to form. So it needs to be very low flow there in order for that thrombus to happen. So you look for that apical aneurysm or inferior basal aneurysm. If there is a mass there, it's most likely going to be a thrombus. For mitral stenosis and AFib, again, that sets you up for a low flow state in the left atrium and the left atrial appendage. So you're thinking that if you see a thrombus there in that sort of patient, or a mass there in that sort of patient, it's likely a thrombus. RV dysfunction. If the patient has RV dysfunction and they have a mass on the RV side, likely pieces of that mass have already embolized or split off and caused pulmonary emboli. So you're thinking that this probably is a thrombus in transit if there's significant RV dysfunction. A tumor invades. It invades the myocardium. It invades the valves. It obstructs the valves. It also causes collapse of the chambers. And of course, the vegetations cause valvular regurgitation predominantly, but can also cause valvular stenosis if they're very, very large. The clinical history will drive you one way or another based on what's going on with the patient. It will be, you will favor one of these 3 categories. So this is a 48-year-old man. He came in with syncope. The syncope happened while he was running. And you can see that he's got a large homogeneous mass in his left atrium. In the upper left-hand panel, it looks like it may be attached to the LA free wall. However, in the right upper panel, it looks like it may be attached by a thin stalk to the interatrial septum. It's really hard to tell in these images, and the only way to tell would be with TEE or some other imaging modality. But this is kind of a classic appearance for a myxoma. 75% of the time it's going to occur in the left atrium. This is the most common primary cardiac tumor in adults. This is a 68-year-old woman who came in with dyspnea, and you can see she has a very spherical-looking mass in her IVC in the left-hand panel. In the right-hand panel, you can see that very spherical mass is now in the right atrium and trying to make its way across the tricuspid valve into the right ventricle. This is a classic example of a thrombus in transit, and because of its size, if this patient was a surgical candidate, you would go in and you'd retrieve it, because this will cause a saddle pulmonary embolus once it gets there. You can see the RV function is still normal in this particular case, so pieces have not broken off yet. So honestly, you would be also saving the RV if you went in and took it out, if the patient is appropriate for that therapy. So this is a 21-year-old patient that I took care of on our inpatient cardiology service. She came in with chills, fever, dyspnea, and you can see that there's a very mobile mass up there in the right ventricle. There's a blow up of that mass on the right upper panel. You can see it looks like it's attached to the intermembranous septum. In the bottom left-hand panel, you can see it's really long and flag-like, and it's reaching way over to the pulmonic valve. The bottom right-hand panel tells you what it is, because you can see that there's a little echolucency inside the mass. That's actually her membranous ventricular septal defect. And this is a huge vegetation on the low flow side, which is the right ventricle side. The reason this formed, because this is very uncommon, is because she subsequently admitted to IV drug abuse and had multiple septic pulmonary emboli in addition to this finding on echocardiography. So this was a 19-year-old woman with lupus and altered mental status, and she came to the lab mostly because the transthoracic showed that her mitral valve was abnormal. She subsequently was diagnosed with lupus cerebritis, and what you're seeing is the mitral valve is abnormal. It's thick. It's not calcified. It's thick from the tips all the way down to the base. This is a classic example of a valvulitis or a Liebman-Sachs endocarditis, and it always occurs when there's a lupus flare, not otherwise, and she was having a really bad lupus flare. She was completely altered. So this is just, treated with treatment of her lupus immunosuppressive therapy. So this is also another unusual case. This is a 74-year-old male who had a history of a coronary artery bypass grafting in 1998. He came in for elective PCI to the distal left main, the proximal circ, and that was several hours earlier, so several hours later, he had hemodynamic compromise. Blood pressure was less than 100. EKG showed lateral ST elevation, myocardial infarction. What you're seeing in that upper left-hand panel is there's a huge mass, and it's on the lateral side, and you can see the LV is small. The upper right-hand panel looks kind of the same, doesn't help much. The lower left-hand panel, you see that mass is completely circumscribed, and it's pushing the whole apex in, so the LV cavity is incredibly small. What that is that's an intramyocardial, sometimes called a subepicardial hematoma. That occurs when you have coronary artery perforation. So this person, his coronary artery was perforated during the procedure. It wasn't recognized that it was a perforation. This huge hematoma developed. It's now compromising the LV and the LV cavity. So this is a surgical emergency. The hematoma needs to be evacuated and the coronary artery needs to be repaired. So is there a role for echo contrast? Well, we said yes in a previous slide. And this is a couple examples to show you where it can be helpful. So this is a 73-year-old with this ischemic cardiomyopathy, and you can see LV's big, function's way down. You can't really see the endocardium at all. You really can't see the apex. But if you look at the epicardium, it looks like it may be akinetic, dyskinetic. It doesn't look like it's moving in the right direction as all the other walls. So this patient underwent contrast, and you can see the contrast. This is a good contrast. You can see equal opacification from the mitral valve all the way up to the apex. And honestly, you really don't see any evidence of any wall motion abnormalities. And because there aren't any wall motion abnormalities, you don't really see any evidence. By I mean akinesis, you see that it's globally hypokinetic, but you don't see any apical aneurysms or inferior basal aneurysms, and you do not see any layered mural thrombi. So this is another 62-year-old man with coronary artery disease. This would be someone you give echo contrast because he can't see the endocardium and he has coronary artery disease. You really can't see the apex, but even the rest of the walls are barely visualized. Maybe the inferior base, the inferior septum, maybe the mid-inferior wall, but the rest of it you really can't see. So he got echo contrast, and what you see is the very distal apex is akinetic, so really, really small apical aneurysm, but it was just enough to cause a local low flow state there, and you can see that he has a very small pedunculated thrombus up there in that very small apical aneurysm. So what about cardiac tumors? We haven't really talked about them much. They're usually metastatic. 95% of the time, they're not occurring in the heart itself, but they're coming from somewhere else. And usually that somewhere else is somewhere in the chest, like the lung or the breast. The metastatic tumors usually always have a pericardial effusion associated with them 75% of the time. So if you see a pericardial effusion and you see a mass, it's going to be malignant, most likely. Primary cardiac tumors, if they're rising within the heart themselves and not coming from somewhere else, they're usually benign 75% of the time. And the most common benign tumor is a myxoma. The most common malignant primary cardiac tumor is an angiosarcoma. And just like the metastatic ones, they frequently involve the pericardium. So you usually have a pericardial effusion. So pericardial effusion is bad. If there's a pericardial effusion at a mass, think that this is probably malignant. So this is a 44-year-old man who came with dyspnea. And when he got an echo for his dyspnea, and you can see that there's a huge mass in the right ventricle, and it's completely filling up the right ventricle. And you can see that that mass is invading into the right ventricle myocardium because there's regional wall motion abnormalities about midway through the RV free wall all the way up into the apex. You can see that mass is also invading onto the tricuspid valve. It's hanging onto the septal leaflet. On the upper right-hand panel, you can see there's a small circumferential pericardial effusion. On the bottom left-hand panel, with contrast, you can see the little speckles inside there. That means it's perfusing. So tumors always perfuse, benign and malignant. Malignant usually perfuse more because they have more of a blood supply. So that's concerning. And then in the bottom right-hand panel, again, you can see the regional wall motion abnormality. The basal RV free wall is moving normally, but the rest is akinetic because the tumor is invading there, and you can see how it's stuck to the tricuspid leaflet. You can't even, the tricuspid septal leaflet, you can't even see it anymore, and you can see there's a small circumferential pericardial effusion. So the path diagnosis on this one was angiosarcoma. This was this 36-year-old woman who was transferred because they found this mass. This is a TEE. You can see it's predominantly at 0 degrees. So what you're looking at is the left atrium up there where the mass is, and as they turn, you're seeing the right upper and the right lower pulmonary veins. So you can, and on the bottom panel, you can clearly see that both pulmonary veins, the upper and the lower, are filled with this mass that's filling up most of the left atrium. This is classic for hematogenous spread from somewhere within the chest, usually the lungs, and this was a sarcoma coming from the lung. She had a known lung sarcoma and was coming for resection of this tumor. So there are atypical presentations, which make it even more complicated. So we talked about how cardiac myxomas are the most common benign primary cardiac tumors. And we talked about how usually they're in the left atrium 75% of the time. But we see them on all sorts of locations. So in the upper left-hand panel, you can see that this is a myxoma that's in the right atrium, and the stalk is attached to the right atrial free wall. In the upper right-hand panel, you can see that's a huge myxoma attached to the basolateral LV wall. And that's only that has a prevalence of 5% of the time. And the bottom hand panel is showing you the surgical view of this huge myxoma that's in the upper right-hand panel. You can see it looks very gelatinous. It's very yellow. You're seeing that he's taken it out. There's the mitral valve there. These tumors can also be multiple if you have these genetic syndromes or these familial syndromes like Name and Lamb. So you can see these all over in any chamber really, but most commonly the left atrium. This is a young woman with Behçet's, and that's an autoimmune inflammatory condition. She came in with dyspnea, and you can see in the upper left-hand panel, she's got some sort of mass that looks like it's attached to the chordae of the tricuspid valve. In the upper right-hand panel, again, you see that mass, and it looks very mobile there. So you're thinking maybe this is a papillary fibroblastoma because it's attached to the chordae and it's very mobile. And again, though, in the bottom right-hand panel, you can see the mass. Doesn't look as mobile there. So of course it was taken out because we didn't know what it was and we didn't know if it had embolic potential. The path showed that this was an inflammatory infiltrate. So of course, if we knew that, she wouldn't have been sent to surgery because the treatment for this is just immunosuppression. So this is a 50-year-old. She got an echo for hypertension. You see her TE images up on the left-hand panel and all her transthoracic on the right-hand panel. And you can see that there's something moving in the apex. The contrast shows it the best on the bottom right-hand panel. It looks like it's a homogeneous mass. It's small. It's near the apex. It's mobile. The funny thing is the apex is moving. You would guess it was a thrombus, but the apex is moving. There's no low flow area. There's no akinesis. There's no apical aneurysm. So this can't be a thrombus. And you're trying to figure out what the heck is it, because this doesn't look like it's freely mobile. It looks like it's attached to something, and you're wondering in your head whether or not it's going to embolize and cause a massive stroke. So in this particular lady who had no symptoms, and this was an incidentaloma, she, let's see if I can get to play, went to surgery. And this is a video of her surgery, courtesy of Dr. Michael Reardon. And you can see that once he gets inside, the left ventricle here, you're going to see inside in just a second. This is our first view. So we're inside the left ventricle. We see lots of trabeculation. We're searching. It's not obvious where that mass is. He's searching, still hasn't found it. So obviously it's not hanging, floating around loose in that left ventricle. Oh, there it is. See it? Right there. It's that very yellow mucinoid-looking mass. Looks very similar to that myxoma that we saw in the previous slide. You can see that, yeah, it's not floating around. It looks like it's very adherent to that trabeculae. And in the next few seconds, you're going to see him try and get it out. And it's going to take a little bit because it is strongly adherent to these trabeculae, which was not visualized on the echo, wouldn't have been visualized on any imaging modality because you can't see the trabeculae. If we would have known it was strongly adherent, we went to center to surgery. But here you go. There it is. He's got a few more cuts, and he's going to get it unattached from all of those trabeculae in the apex. The apex is very, very trabeculated. And I'm guessing if I took a vote, everybody would think that that probably was a myxoma in an atypical location, right? Well, it got sent to path, and it actually came back as a papillary fibroblastoma. And that's a very unusual case for a papillary fibroblastoma. And papillary fibroblastomas are not supposed to look like that on gross specimen. They're supposed to look like sea anemones with lots of little fronds. That did not look like that. So don't have an explanation for why it didn't look like it's supposed to look, other than possibly because of the unusual location. It wasn't on a valve, that maybe that's why it didn't particularly look the way it was supposed to. Now, is there a role for echocardiography after stroke? Absolutely. It allows the identification of an intracardiac mass, such as a thrombus tumor vegetation that may have partially embolized. It allows identification of abnormality that may predispose the patient to the development of an intracardiac thrombi, such as mitral stenosis, left atrial enlargement, spontaneous echo contrast consistent with flow stasis. LV aneurysm or aortic atheroma. It allows the identification of a cardiac abnormality that may serve as a potential source for systemic embolization, such as a patent foramen ovale, atrial septal defect, or Lambeau's excrescence. A definite cardiac source, though, in a patient with a cardiac source of embolus, it varies from the series that you look at, but somewhere between 15 to 40%, so not that great in somebody who has an ischemic stroke due to cardiac source of emboli. So this is a 64-year-old woman. She came in with facial droop and left arm weakness, so she was having a stroke. This is her first echo images. You can see that there's a very large mobile mass that's floating around in the left atrium. You can see it's trying to get across the mitral valve. You can see the right atrium is very big, and this patient's obviously in atrial fibrillation. So this becomes a surgical emergency because she's already had one stroke. This is a huge thrombus. It's in transit. It's on its way. So you need to get it before it ends up in her brain. And that's exactly what happened in this particular case. The surgeon went in, took out that huge mass, was a thrombus, just like we thought, and the patient did well. The patient eventually had full neurologic recovery. So the other role for TEE is to check out the ascending aorta to look for atheroemboli, specifically ones that have ulcerated. Because if they have ulcerated, that could say that that was the source for the cardiac source of embolus, because that piece is missing, that piece broke off, that piece embolized. On the upper right-hand panel, this is a classic view using TEE of an ulcerated atheroma. And again, of course, we always look at the left atrial appendage to rule out, especially in patients with atrial fibrillation and stroke, to rule out any sort of evidence of early flow stasis, early thrombus formation. This is what early flow stasis thrombus formation looks like. It fills up the distal part or the tip of the left atrial appendage first, and then frequently a layer on the inferior wall of the left atrial appendage. So this is a classic example of early thrombus formation. And then the very last thing that we always do is look for a patent foramen ovale or an atrial septal defect. In this particular patient, you can see that the septum is very mobile, either redundant or a septal aneurysm. You can also see that there's a eustachian valve there. And when the contrast comes, there's a patent foramen ovale, which, as we mentioned, it has a higher likelihood of occurring in patients with atrial septal aneurysms. This was an unfortunate patient who came and had both a PE and a stroke at the same time. He was hospitalized in the intensive care unit because he had both. And this is a TEE picture because the echo showed masses of both the left atrium and right atrium, and we needed the TEE picture to try and figure it out. So what you're seeing here is, there's a mass in the right atrium, there's a mass in the left atrium, but that mass is stuck across a patent foramen ovale. So this was somebody who the mass was removed and the patent foramen ovale was closed, because the odds of this actually occurring is pretty small anyway, but the odds of it reoccurring is much, much greater in somebody who is predisposed to this happening. So I'm going to end with a very atypical presentation of somebody with a stroke. This is a 67-year-old woman. She has lupus and she had a stroke. This is a picture of her mitral valve. You see a very homogeneous mass, tightly adherent to her posterior mitral valve, and it's on the atrial side, so low flow side. This is her intraatrial septum. You see a much larger mass, but looks very similar to the one on the mitral valve. Very homogeneous, tightly adherent to the intraatrial septum. It's in the left atrium. Let's go. So here we go. So this is her ascending aorta. You see a lot of atherosclerosis, and also in the bottom hand panel, you see an ulcerated plaque with mobile components. So this lady, she unfortunately went to surgery, because this is a classic presentation of somebody with antiphospholipid antibody syndrome with clots all over the place. Those clots can occur anywhere in the heart. She has lupus. She likely has lupus anticoagulant. That's one of the antiphospholipid antibodies. She ended up having, it wasn't checked. in this particular patient. So the diagnosis was never made, but she just needed more blood tests to see if she had the other two antiphospholipid antibodies. Unfortunately for this lady, she went to the OR and they removed them and they all came back thrombi, but she suffered a huge post-op stroke and never gained neurologic recovery. So this is just a reminder to everybody, and somebody like this, with this clinical history and multiple thrombi, you really need to rule out antiphospholipid antibody syndrome, because the treatment here is just anticoagulation, warfarin with an INR of 2.5 to 3.5, and all of those thrombi will go away. So according to the ASC appropriate use guidelines, talking about the use of echo and the evaluation of cardiac source of embolus, I'm not going to go through all these, but I'll just give you a summary. TTE is always appropriate. If the neurologist says it's a cardiac source of embolus, you need a TTE. TEE is also always appropriate. If the neurologist says it's a cardiac source of embolus, TEE is appropriate. I know we do a lot of these in the lab, but there's a reason for it. Frequently, we do find things that could alter the treatment plan for that particular patient. And with that, I'm going to turn it over to Dr. Nabi.
Thank you, Carla. Okay, so what do I just... Okay. All right, so I've been tasked with showing how advanced imaging can help in the assessment of cardiac masses, and once you've completed your echo. Okay. So, as you probably saw in the slides that Carla showed, usually, one of the first places where we identify a cardiac mass is usually on echocardiography. And then the differential frequently is something that we have seen a lot of images of in the last half hour. Is it a tumor? Is it a thrombus? Is it a vegetation? Or is it something what we call a pseudotumor, which is, really, is it just an artifact or a normal variant, a normal structure? And what's important is, as Carla very nicely showed you, is in order to determine an etiology, you really need to integrate all the data. It's not just about imaging. You got to know the age of the patient. You got to know their past history, just as we saw in this last case with the lupus case. You need to know where the lesion is. And if you have the ability to, and what I'll be showing you in the rest of my talk, how the addition of non-invasive tissue characterization with either CT or CMR can be very helpful. So Carla, and just a little bit of redundancy between our talks, it's, when it comes to identifying lesions, it's also important to know where common lesions hide. I won't spend too much time. Carla went over this in great detail. But each of the different, chambers of the heart have more common lesions that can present there, and it's important to know both normal variants that are there in those structures, as well as common lesions that can arise from them. But my job today is really to show you how, when it comes to determining etiology, the addition of advanced imaging can really help in addition to echocardiography. And it can help you by, asserting whether the presence of a cardiac mass is truly there, to help you determine the exact location within the cardiac structures and whether it's invading or not, and then to help you possibly to determine if the mass is benign or malignant. And so the rest of my talk is really focused on cardiac MRI, CT, and a little bit of PET. So echocardia, Carla already showed you all the tremendous advantages. It is the first-line test. It gives you great Doppler information, but there are some disadvantages that we should be open about. There are acoustic window restrictions, so you have limited field of view, frequently of the right side of the heart. If your patient has COPD or obesity, you may not be able to visualize things well. And you really have, because it's a triangular field of view, you really, it's a small field of view. You really don't have full information what's going on in the chest. Other than calcium and maybe fat, it really has poor soft tissue characterization. And when it comes to, TE is semi-invasive. So what about these other tests like CT and MRI? And when we compared them to echo, there are some distinct advantages that can add value to an echo. These tests all, I'll mention this many times, they all have excellent spatial resolution, temporal resolution, large fields of view, so you're really able to see not only the heart, but the entire chest. You can do perfusion assessments with them, as I will show you, and MR better than CT, the ability to where really the difference with advanced imaging is the ability to do tissue characterization. All of these, strengths that these techniques have, really then allow you to really visualize the lesion in great detail to be and to able to really describe well what you are seeing. The tumor anatomy, its shape, its size, its location, whether it's invading tissues, because this becomes very important for tissue, for surgical staging, whether it's extended and where it's extended to or where it's extended from, how vascular it is, and these techniques you'll see basic tissue contrast we can figure out. So let's begin with CT before we get to some of the other modalities. Now, this is really the test which has the highest spatial resolution, and it's got a large field of view, so you're going to see things exceptionally well inside the chest. We have the ability to do multiplanar reformats, so no matter where the structure is, we will be able to visualize it. These are in patients who may be claustrophobic or hemodynamically unstable. Because of its fast acquisition times, it can be very helpful. It's important for these studies that we should note that these studies should be gated to avoid any sort of motion-related artifacts. And as I had mentioned, there's several ways we can analyze the data. We can look at soft tissue windows, bone windows, lung windows. All of us will tell us in great detail where this lesion is and to be able to describe it well. And this becomes very valuable for the surgeons because it helps them in their surgical planning. But not only that, if this patient is headed to the operating room, it's frequently important to know whether they have coronary disease. And of course, these are techniques that can also visualize the coronary arteries. And sometimes also are able to get, if you add the abdomen and pelvis, you can actually stage the disease should this patient have metastases in other locations. So it can be very helpful. And CT, as I will show you, has some basic tissue characterization which can at least identify some simple lesions like those that are calcified or lipophilic. What is our basic protocol? We'll always start with a pre-contrast study, which is really a non-contrast study, where these images are very important because they can help identify where calcium is or where metal is. We follow that by the addition of contrast, and this is really when we get to see the vasculature and appreciate the mass. And then finally, we'll also do a post-contrast image, usually taken 60, 90 seconds after the initial study. And here we're specifically looking for contrast uptake as a measure of vascularity of the particular mass. When it comes to tissue characterization, as you know, we perform this with, by measuring a CT attenuation. This is given in Hounsfield units. Water, as you know, is 0. Fat has a very characteristic Hounsfield unit. It's generally less than 100. Air is less than 1,000. Bone, is more than 1,000. So you can see here very simply and quickly that, identifying calcified structures is very easy. Identifying anything that's water-based is quite easy. Anything that's fat-based is quite easy, or of course, air is very easy. Now, where we have, difficulty is in the soft tissue range. But there are a lot of masses that you can very easily rule out with CT. So here's, Carla showed cases like this. I'll just show you what they look like by CT. This was a case by echo, again, that very tuberous calcified structure there on the lateral annulus. This is what it looks like with contrast on your bottom left side of the screen. But what's really helpful is the non-contrast CT scan. Here you can see that this is calcium shows up in these structures in these images very nicely. You can see this is a very densely calcified lesion, and this just happens to be an example of caseating MAC. How about this? This was two hearts that had a lot of density. One here in picture A around the intraatrial septum, and then one around the ventricles. You can see it's a very dark-looking image. When we measured the Hounsfield units here, this was less than 50 minus 100. This is very consistent with fat. So this is an example of lipomatous hypertrophy gone wrong in the first image, maybe even a lipoma, and then some lipomatous condition of the left ventricle in image B. We can also, with CT, look for thrombus, specifically left atrial appendage thrombus. We have specific protocols for this. What you need to do is you have the first pass perfusion images, which we'll call the arterial phase in the top set of images, and then we'll do a delayed set of images afterwards. And the concept will be the very same between CT and CMR, and that is that thrombus should not take up contrast. So if you look at a normal left atrial appendage on the left, you can see both on the arterial and delayed scans, you have complete opacification of the left atrial appendage. If we look on the far right, you'll see a filling defect on the arterial phase, which is in the middle group, a filling defect on the arterial phase with persistence of that filling defect on the delayed phase. So, this is very reminiscent of thrombus. Thrombus does not take up contrast, and contrast this to what you would see on the very right side of your screen, where you see a filling defect on your arterial phase, but then that fills in on your delayed scan. This is an example of slow flow or stasis, which we frequently also can see with TEE. So it's just a nice way of how when we do a lot of cases now, pre-ablation, when we have to rule out left atrial appendage clots, how we use both our arterial and delayed scans to make that diagnosis. Just a few images of CT, which can be very helpful. Obviously here, tissue characteristics may not have been, that answer by itself. This is really where you need to integrate all the data, as myself and Carla have been speaking about. This was a valvular lesion on this patient on the top group of images, very nodular. If you were to look very, very closely, maybe you could imagine it has a frond-like appearance. This was typical of papillary fibroelastoma, again involving the valve. And then in the bottom set of images, the characteristic images we know here of a pedunculated mass attached to the left intraatrial septum here, and on CMR, a little bit of contrast uptake, very, very kind of pathognomonic for a myxoma. Now, there are ways to look at vascularity when it comes with the use of CT. With our photon counting CT, we now have the ability to do, assess our mass under different KEV scenarios. And this is just a study that was out there using dual energy, which kind of shows the same concepts. But the idea is to create an iodine map, which is that middle group of images, to see where all iodine or contrast has made it. And you can see in all three of these images, other than the bottom one, which was a thrombus, that there is evidence of iodine both in the myxoma, there in the top, the lymphoma in the middle, suggesting that whenever you do have contrast uptake, that this is a vascular mass. This has some vascularity to it, this mass, and is usually pathognomonic for a tumor. Contrast that with a thrombus. Here you'll have no evidence of any contrast uptake, and this is further just quantified by this ability to do an iodine map with dual energy CT. Studies were just recently published, which you know, that if you were to go about how do you figure out if you do see a mass by CT, you know, short of a biopsy, how can we define whether this is a malignant mass or not? So in this particular study, they, you know, they came up with a list of about 8 criteria here: irregular margins, pericardial effusions, calcification, invasion, size greater than 3 centimeters, any solid component, isodense signal, and contrast enhancement. And they said that in this study, they showed very nicely that if you have at least 5 or more of these signs, you really have a specificity of 100% for identifying a malignant mass. And some of this is common sense. You know, if you see contrast uptake, a very large mass that's invading, you know, we all know that this is more than likely a malignant lesion. On the flip side of it, if you had less than 2, you know, it was more, you know, probability of being a malignant mass, the specificity was only 15%. In this study, what they also did was, in those, you know, if your patient only had 3 to 4 of those findings, they actually found the addition of cardiac PET to be, cardiac PET to FDG PET to be very helpful. And in those cases where you would find an SUV more than 4.9, those lesions all turned out to be malignant. So just something, you know, if you happen to be rounding and you have a chance to see a mass on the surface, you know, sometimes we can use a combination of these studies to help figure things out before they hit the operating room. So just again, advantages, you know, it's fast, you know, you get the coronary information and you can really identify calcified fatty lesions. Disadvantages, of course, you're going to expose to radiation, you're going to get some contrast, so be careful in, you know, renal insufficient patients, possibilities of allergic reactions to those who are susceptible, not the best temporal resolution with CT, and soft tissue, you know, pretty good with looking at air, fat, bone, but maybe not so good with other things. So we'll turn our attention to FDG PET. You know, this is a technique, as you know, where you administer radio-labeled glucose after the patient is in a fasting state. And the idea is that the more metabolically active your mass is, the more likely that that lesion is a tumor. And if it's very metabolically active, you know, more likely that it's malignant. So again, as I had showed you in the last slide, it can be very helpful in inconclusive cases. And it can definitely, if you can do a full body PET, it can help you, you know, stage the disease. Limitations are, you know, there is a prep involved. It can, you know, patient has to fast. And, you know, if they're diabetic, you know, may have to undergo a clamp, you know, all kinds of things like that. So that can be a little bit problematic sometimes. And of course, it may not necessarily be available everywhere. So this is just a case that was seen here, not seen in the literature, where there was a mass in the right atrium, and there was some question of whether if this was a tumor or not, and sure enough, it lit up very significantly on your PET images. This was the study that I was alluding to. If you just now focus on the middle panel there, you can see that if you have intermediate signs of malignancy by CT, if you're not sure, you know, proceeding with a PET can be very helpful. And if you have an SUV max more than 4.9, it was pretty much 100% specificity for a malignant mass. Now, really, where the rest of my talk will be CMR, and what I want to emphasize with CMR is it has a lot of the strengths that we already talked about with CT. You know, it has the high spatial resolution, but here, in addition to that, we have the high temporal resolution, the wide field of view as well. It's completely radiation-free, but its biggest strength is its ability to do tissue characterization. So with that, we'll be able to identify a lot of different lesions, as I'm going to show you in the next few slides. And I'll show you that it actually now has pretty robust data and able to distinguish between benign and malignant lesions. This technique really, you know, I want you to think of it as a non-invasive biopsy. You know, not only can you localize the lesion in great detail, you can describe it, you can tell whether it's invading or not, whether there's any tissue pericardial effusion associated with it, tissue characterization. It's really a comprehensive assessment of your mass. We have a very structured protocol for how to perform this study. It's important to mention only because it's going to show you how we actually go about interpreting these studies. We have some basic, what we call bright and dark blood images of the chest. We'll do some specific SSFP cine imaging of the heart and the mass itself. We'll follow this with some tissue characterization, which is without contrast, which is our T1 and T2 images. We'll then give contrast and watch vascularity of the mass. This will then be followed by our LGE sequences that you all are all very comfortable and familiar with, and then our long TI imaging, which are sequences that specifically look for thrombus. I'm going to focus on the tissue characterization part of things because this is obviously the strength of CMR. We have the pre-contrast images, as I had mentioned. This is where you look for T1, T2, T2 star. Anything that's bright on T1 usually is something like fat or acute blood. Anything bright on T2 suggests edema or water. T2 star sequences are for iron. When we give contrast, we're looking again at the contrast images in three kind of spaces of time. One is the first pass perfusion, where we can tell a vascularity of a mass. The second is looking at delayed hyperenhancement, which tells you a lot about also vascularity, fibrosis, necrosis, inflammation of a mass. And then your long TI imaging, which is specifically for thrombus. Again, all very important in helping you to create a differential diagnosis that takes into account all the other things that we had spoken of. In general, whenever we approach a mass, the slide was made for MRI, but we do the same for CT. First thing I do in my mind is I try to figure out, okay, what I'm seeing, is this a true mass or is this something a pseudomass? And pseudomass here, I mean, is this just a normal variant? Some structural abnormality that we're seeing? Is this an artifact in the image? Once we've said, yes, this is a true mass, my next question is this what we call a pseudotumor? And what I mean by that, these in general are things like fat, fluid, calcium, thrombus. They all have kind of a benign prognosis, as opposed to something, as opposed to a tumor, which, as you know, has a different prognosis. So in general, in step 2, we're trying to figure out whether it's a pseudotumor. Pseudotumors do not take up contrast, whereas all tumors will take up contrast. So this becomes another very important finding. And then the third is to try to create a differential diagnosis of whether this lesion is benign or malignant. So this was just a paper that was published in the literature that kind of had their own way of creating, questions that you ask yourself when doing a mass, but very much the same kind of concepts. But they went a little bit into some features of benign and malignant tumors. And, as we know from what Carla has showed and what I have also showed, malignant tumors in general tend to be ill-defined, infiltrative, a lot of heterogeneous contrast uptake, and, some imaging features of, malignancy. So let me give you some examples of some cases from our own lab. Here was a structure that was bright on T1. And then when you did your T2 images with fat saturation, you can see this image is dark. I don't expect y'all to know MRI, but maybe, if you've been aware in the last quite a few lectures that we've had, tissue MRI is actually assessing, intrinsic properties of the myocardium, physical principles of the myocardium. So there's nothing else that is bright on T1 but dark on T2 other than fat. So this is a very nice example of a myocardial lipoma. And then we can very simply do this just by getting these, T1, T2 images. Here was another structure. This was actually outside of the pericardium. It was, if you look at it, you can see it on A. These were our SSFP images. On the T1 images, it was dark. This was kind of reversed from what we saw with the lipoma. Dark on T1, bright on T2. If you remember, T2 is edema or water imaging. So this, again, this combination of dark T1, bright T2 really can be nothing else other than fluid. And this, the weight, where it was located, the well-circumscribed kind of features of it, this pathognomonic T1, T2 without any evidence of contrast uptake. This is very, this is a pseudotumor and a pericardial cyst. Here was an example of, we've seen this now many times, but just to show you how it looks with CMR, here, this lesion at the lateral annulus was dark in all imaging with all tissue characterization techniques. Dark on T1, dark on T2, dark on first pass, and dark on LGE. This is very pathognomonic for calcium, as was seen on the non-contrast CT. You've seen this a couple of times. But the concept is very simple. With MRI, we image protons. There is no protons to be imaged in this calcium blob, and hence it was dark in all our images. So very easy to sometimes identify large calcified lesions. Here was a lesion that was identified in the septum in your baseline images, and when you did your long TI imaging, you can see it's completely black, meaning this was, again, remember, after the administration of contrast. There is no evidence of contrast uptake of this lesion in the anterior wall. This is very much pathognomonic for thrombus. So just this ability to, assess the intrinsic physical, tissue characteristics of a substance can be very, very powerful. And this patient did not go to the operating room. They were put on anticoagulation, and here you can see within a short period of time, the MRI was repeated. That mass lesion is completely resolved. Again, corresponding to and supporting the diagnosis of LV thrombus. So studies have shown, when it comes to differentiating between tumor and thrombus, it can be actually relatively straightforward with CMR in most cases. Thrombus in general will avoid contrast. So you will, you're not going to have any first pass perfusion. You're not going to see anything on LGE imaging, no contrast uptake, and no contrast uptake on delayed TI imaging. Tumors behave, because they're vascular, behave very different. Any sequence which has contrast, they will uptake contrast. It's a very important differentiation to know. Tumors as well on T2 imaging, because they frequently have necrosis and inflammation, will be bright on T2 imaging, suggesting there's edema present within them. So here was a lesion that was at the apex of the heart, round, we're all wondering, what is this? On T1, you can see it's dark. T2, really, it looks a little, maybe a little bit brighter than the myocardium. And first pass perfusion, really not much uptake, but very, very characteristic findings on your delayed hyperenhancement lesion images. You have significant contrast uptake by this mass. So this is where now you kind of use some deductive logic. This is an LV mass that has taken up significant, it's at the apex of the heart, it's taken up tremendous amounts of contrast. This is very pathognomonic for a LV fibroma. And actually, we see this not so infrequently in the CMR lab. Here was 2 cases of masses. The first panel, there you could see it's attached, it's a pedunculated mass attached to the left atrial septum. And in the bottom panel, you can see this large mass in the right atrium, and seems to kind of extend beyond the borders into the pericardium. Tissue characterizations for both of them, what I'd like to point out really, again, both were bright on T2, and both demonstrated contrast enhancement, both with first pass perfusion, although the myxoma, which is the top image, did not have as profound first pass perfusion as the sarcoma, but on the delayed hyperenhancement images, both took up contrast. Again, the myxoma less than the the sarcoma. So by CMR, both are very, pathognomonic for a tumor. and especially the second one would be very concerning for a malignant tumor because of some of the other features that we spoke about. And really, this is a study that was recently published. It's called the CMR mass score. And so a lot of this is, common sense to what we've kind of seen in the literature, and, that if you were to if you were to look at your images and sum up a weighted score that includes infiltration, a polylobate mass, a pericardial effusion, a sessile lesion, something that demonstrates first-pass perfusion and has heterogeneous hyperenhancement. If you have a score more than 5, they showed an AUC of 0.98 for, as and 0.98 showing that it can be maybe a very reliable score in helping you to identify a malignant lesion. So, I think the most important thing to get out of this is just not to remember the score, but to remember features that when you are looking at a cardiac mass to, prompt you to, think about that, hey, this is something serious. I should call the referring doc. This looks like a malignant lesion. This was also studied here in our lab with Dr. Kasi and Dr. Shah. They also came up with diagnostic criteria. Here they looked at basically 3 variables to figure out whether something was benign or malignant. They looked at whether it was infiltrating. They looked at how much first-pass perfusion there was and the size of the lesion. And they showed that just using those 3 things, they had a diagnostic accuracy here of 92% for diagnosing something as malignant. So the bigger it is, the more invasive it is, and the more contrast that it uptakes are all signs of something bad. And this final slide just goes to show you that what we tell you in the CMR lab has prognostic value as well. So this was a study that looked at 903 patients with masses. You can see the distributions of the masses here, either no mass, a pseudomass, a thrombus, a benign tumor, a malignant tumor. And if you look at the long-term mortality, you can see very nicely that if we were to tell you your patient has no mass or pseudomass, these patients have a very good long-term prognosis, whereas something like a malignant tumor there in the orange line, has a bad prognosis, and that we are identifying benign and malignant features relatively reliably. So just a quick slide to show you how we can use these different imaging techniques in different situations. And I will just leave this slide up for some take-home points. Any questions for Carla?